this is Bob Harrington on Medscape Cardiology and theheart.org. Over the past couple of months, Mike Gibson and I have done a series of podcasts trying to have some discussions about what were the best trials of 2017, trying to comment on some of the other issues in cardiovascular medicine outside of the trial world that our community is talking about. We thought in this one we would talk looking ahead, and rather than thinking about the data that's in hand, we would be thinking about the data to come. Let me introduce my friend and guest today, Mike Gibson. Mike is an interventional cardiology at the Beth Israel Deaconess. Mike is a professor of medicine at Harvard Medical School. He's the CEO of the BAME Clinical Research Institute, and he is the founding director of Perfuse. Mike, thanks for joining us here today on Medscape Cardiology.
Good to be back with you, Bob.
So, Mike, as you heard in my intro, you and I covered the landscape of 2017, sort of what had happened. And a number of colleagues, as those pieces rolled out, said, well, what's going to happen? So this is a great opportunity for you and I to reflect upon some of the areas of cardiology that important trials are being done and that should be released in 2018 or maybe at the latest 2019. Let's start, Mike, with lipids, which remain an important topic. And in the light of the Fourier results being one of our key trials from 2017, the Odyssey ACS trial is a big piece of news in 2018. I will preface your comments, Mike, by telling our audience that I'm a member of the executive committee for Odyssey, and to the point that we're doing this recording, I have not seen any data yet. So with that, why don't you tell people what Odyssey is and what you're thinking about?
Yeah, thanks, Bob. I think this follows on to the news that we had about Fourier last year. Fourier was a slightly bigger study. I had stable patients with, in many cases, multivascular disease who had some PAD or stroke and a prior MI. The way Odyssey differs from this is these are patients who had an ACS event, either up to 1 month to 1 year before this. Not an acute period right after the event, but a little later, 1 month to 1 year after that acute event. And in contrast to Fourier, where people got a fixed dose of the PCSK9 inhibitor, in this trial, there is up titration of the dose. So if you don't achieve an LDL less than 50, the dose is doubled and upwardly titrated. That's really important, I think, intellectually, because many of the epidemiologists pushed back on the lipid field saying no trial had been done really targeting an LDL. So this is clearly a trial that is targeting an LDL target, say, of 50, and that will be very important when it comes to looking at the guidelines if this is indeed positive. So another differentiating feature is the duration. Whereas Fourier went about 2.2 years, this is going to go 3 years. Of course, Fourier was criticized for going too short to see a benefit. This will give us a little more time to see a benefit in this study. On the other hand, the LDL lowering here is anticipated to be lower at about 50 to 55%. Versus Fourier, which was higher at about 60%. And again, the study is smaller than Fourier. A little higher statin dosing in Odyssey, high-dose statin dosing, and that may again erode the benefit. So we'll see. This is going to be a hot trial. It will be presented early on at ACC 2018. If it's positive, this will be a second big outcome study. Hopefully it will encourage insurers to be somewhat more liberal in allowing physicians to use the class of drugs that improve outcomes.
I'm totally with you, Mike. If this becomes the second of the big PCSK9 inhibitor outcomes trial, now we will pretty firmly have 3 drug therapies that lower LDL, statins, ezetimibe, and PCSK9, that by lowering LDL reliably improve clinical outcomes. And one of the things you alluded to but didn't explicitly state is that I think a lot of us are looking to see cardiovascular mortality. Were the Odyssey patients followed long enough to observe that effect on mortality that was not seen in Fourier? So we're all looking forward to the ACC and seeing these data roll out.
Yeah, it's going to be interesting. These are higher risk patients. That's the good news. The bad news is that there may be more thrombotic events early on after enrollment where you may not see a benefit of the PCSK9. It's going to be interesting to see what the study shows.
Yeah, you remember in Improve It, that was part of the key issue with ezetimibe, is that the early period of risk wanted to make sure that that wasn't necessarily ascribed to the randomized treatment. In fact, that you had that longer period of follow-up after 1 month of initiation of the therapy, whereby you could see more of what might be considered the LDL lowering effect, as opposed to some contamination by the thrombotic risk effect early on. Staying in the lipid field, but moving from LDL to triglycerides, REDUCE-IT's an interesting trial because this is going at that notion of by reducing triglycerides with omega-3 fatty acids, can we improve clinical outcomes? And this is an area where there's a lot of anecdote, a lot of small and observational reports, and no clear consensus as to whether or not lowering triglycerides actually improves cardiovascular outcomes. You want to comment on this one?
Yeah, there's some fascinating data from the GISI group showing some benefits in heart failure. Of course, there's some animal data showing not just lipid changes, but stabilization of membranes and reduced arrhythmias. Of course, we know that the Japanese population and people in the Pacific Rim have higher fish consumption, and there may be some health benefits there. This is looking at EPA or eicosapentaenoic acid omega-3 at a pretty high dose of 4 grams a day on top of a statin. The idea is that by reducing the triglycerides, which some people think are an independent risk factor, whether outcomes can be improved. This is randomized, double-blind, placebo-controlled. You had to have an elevated triglyceride level of about 150, over 150, and less than 500 to get in. You had to be on a stable statin dose with an LDL of 40 to under 100 and have some CV risk factors. And then you're randomized to just staying on that stable statin or getting Vascepa on top of it. Study started in 2011, 400 sites, 11 countries, event-driven. A total of 1,612 adjudicated events will be analyzed over 4 to 6 years. Those events are cardiovascular death, MI, stroke, revasc, or unstable angina. A little bit of a soft endpoint there at the end with revasc and unstable angina, hard endpoints in death, MI, stroke. So the trial has completed enrollment and has hit the number of target events pretty soon.
A lot of us are awaiting this one, right? We all see coronary disease patients who have elevated triglycerides, and I think that the data's never been clear enough to mandate or to have a high level of guideline recommendation to use triglyceride-lowering therapy in this range that you're talking about, which is not the excessively high, but is certainly above the upper limit of normal. So more to come on that one. A lot of interest in the general cardiology community, the preventive cardiology community, and the lipid community. Yes, turning our attention, Mike, to antithrombotic therapy. Let's do both antiplatelets and anticoagulants. First off, the notion of dual antiplatelet therapy post-stenting, which has always been thought to, at least over the last, let's call it 15 to 20 years, has always been thought to require an ADP inhibitor plus aspirin. Those questions are being raised as to whether or not you need both agents for the long run and what that duration is. And we've had important trials like the dual antiplatelet trial, the DAP trial, which has certainly asked that question. But the question continues to be examined, and we have 2 trials that we expect to see later this year or early next, one called Global Leaders and one called Twilight. You want to try to put the field in context and then pull these 2 trials in specifically as to what they're looking at?
Yeah, you and I were around when we gave dextran, persantine, aspirin, warfarin with 8 to 10 French sheets in someone who we put an old Palmaz shot stent in. You and I both remember when ticlopidine was introduced, and aspirin plus ticlopidine turned out to be better than warfarin. And
the STARS trial.
Yeah, the STARS trial. So that really cemented the role of dual antiplatelet therapy. We've come a long way since then. We have newer stents that are less thrombogenic, and we also have drugs that are more potent than, say, ticlopidine. And while there has been some studying of extending DAP, most of the interest comes in shortening the duration of DAP, and there's a lot of recent interest in getting rid of aspirin. Remember that thienopyridines beat aspirin for instance, clopidogrel, back when those two were studied head-to-head. So the question is, could we drop aspirin and still preserve good outcomes? And aspirin, of course, inhibits prostaglandin synthesis, causes GI bleeding for that reason, is a vasoconstrictor. Of course, Bob, all our audience knows that in the WOOS trial and Pioneer trial and others where we dropped aspirin from triple therapy, we had less bleeding and as good, if not better than efficacy outcomes as well. So Global Leaders is a big trial of about 16,000 patients. It's an all-comer PCI trial. People are getting the biomatrix stent, and it's open label, 2 arms. Everyone's getting either ticagrelor for 24 months or aspirin for 24 months. Now, over in the ticagrelor arm, you get aspirin for 1 month. So it's ticagrelor plus aspirin for a month, and from there on out, ticagrelor. Over in the other arm, the conventional DAPT arm, you get ticagrelor plus aspirin for 12 months if you're an ACS patient, or Clopi plus aspirin if you're a CAD patient. And then from 1 year on, it's aspirin monotherapy. So ticagrelor for the majority of time alone, or a little mix of DAPT for 12 months, plus aspirin monotherapy for another 12 months. Now, I think this is going to be a tough lift. By dropping aspirin from the ticagrelor arm, they expect to show superiority in ischemic outcomes, mortality, and non-Q wave MI. For the bleeding side, they expect to show a reduction in BARC class 4 or 5 bleeds. Will dropping aspirin from DAPT and just giving ticagrelor alone, will that improve outcomes versus aspirin alone? Is going to be interesting. Go ahead, Bob.
I was going to say there's so many levels of interest on this for me. The first of which is that we're really seeing an error with these antithrombotic trials of what I would call strategy. As you and I did trials throughout the 90s and early 2000s in this field, it was largely trials that were testing a drug against either another drug or against placebo. Now what we're really starting to see is what's the optimal strategy, and we're also starting to see what's the optimal balance for patients. Improving ischemia is good, but not if it comes at a big cost of bleeding, and so how do you balance those two? And then the final thing I'm sure our audience is thinking about, whoa, you're getting rid of aspirin. And how many times, Mike, did we talk over the last 25 years, we couldn't possibly get rid of aspirin, that's backbone therapy. So a lot of interesting things coming out of a trial like Global Leaders.
When you go back and look at the history of aspirin, it was really launched with ISIS-2, showing an improvement in outcomes with a lytic agent, a little more spotty outside of ISIS-2. So we'll see. But it's not all good with aspirin. It does cause bleeding. It does cause some vasoconstriction.
Well, move us into Twilight.
Yeah, Twilight is slightly different. Again, all-comer PCI trial of 9,000 patients. But here, everyone gets 3 months of ticagrelor and aspirin, and then you either get ticag alone or ticagrelor plus aspirin. So again, dropping aspirin in one arm. In this trial and the other trial, Bob, I want to make it clear, everyone's getting aspirin, say, for a month in Global Leaders. Everyone's getting aspirin for 3 months here. So not complete early withdrawal of aspirin, but a shortened period of aspirin. The primary endpoint here is bleeding and superiority in BARC 2, 3, and 5 bleeding for ticagrelor alone. And then the idea is hopefully there will be non-inferiority on the ischemic outcomes, cardiovascular death, MI, ischemic stroke, and ischemia-driven revasc. So that seems like an easier reach to show that you reduce bleeding by getting rid of aspirin and that you preserve efficacy with non-inferiority. So that design and statistical design looks to be more within reach.
And it also looks to be a little easier comparison for the reader to understand, doesn't it? This, to me, fulfills the classic definition of when non-inferiority trials should be used, is because, as our listeners know, you always give up something in non-inferiority. The question is, what do you get in return? What you're trying to get in return here is less bleeding and less important bleeding. So I like the construct, and we'll see if they fulfill that, non-inferiority on ischemia and benefit on bleeding.
The other trial in the antithrombin space is more of an anticoagulant trial, and that is the Voyager PAD study. Kind of building upon what was seen in COMPASS, remember the COMPASS dose was this reduced dose of rivaroxaban, the 2.5 milligrams twice a day plus aspirin, a regimen that we studied back in ATLAS. Obviously, in both those trials did quite well, including a reduction in mortality in both. This study looks at that regimen in the peripheral arterial disease patient. They're looking at people who recently had a peripheral arterial procedure distal to the iliac, and you had to have symptomatic PAD. You had to get randomized within 10 days of the event, or the revasc, I should say. And it's, again, a trial of that low dose of Revo plus aspirin versus aspirin alone, 6,500 patients. It's event-driven, 1,015 endpoints to be reached with about 30 months of follow-up, so pretty long follow-up. And the results are being stratified as to whether you had a surgical or endovascular procedure and with and without clopidogrel. So we'll see if the results of the ACS and CAD side of things are extended over to the peripheral interventional side of things. In COMPASS, the PAD cohort did well, but we'll see if the interventional cohort does well here. Not a lot of therapies have worked in the interventional side of the PAD population.
You've hit the highlights of Voyager at PAD, and I'll just stress a couple of points, one of which is something you and I have talked about on these podcasts before, is anticoagulants against antiplatelet agents. Not that one needs to pair up one against the other, but there are some interesting observations that the anticoagulant over time seems to be emerging as a powerful addition to the post-event, I'll call it, regimen, whether it's in coronary disease or other aspects of atherosclerosis. The second is the final point you made, Mike, which is we have trials like Euclid with ticagrelor that didn't show any benefit of ticagrelor in a PAD population. Finding something that works in the PAD population, boy, this has been tough, hasn't it?
It has. You and I both know these people are frequent flyers, too. It's not just one event. The rehospitalization rate after these revascularizations is very, very high. So very costly, frequent flyers, unmet need is going to be interesting.
I think there's a lot we'll learn here, and putting it into the context of other PAD trials, I think will be an important thing to consider. Two more trials to go, Mike, one from interventional cardiology and one from interventional electrophysiology. Let's do the interventional cardiology trial first. You and I talked in our 2017 discussion about culprit shock and how interesting those results were about shock-related artery revascularization versus more complete revascularization. Now we have a trial complete, which is looking at a broader cohort of patients undergoing PCI for acute myocardial infarction and asking the question, complete revascularization versus targeted revascularization. You want to give your thoughts on complete?
Like you said, broader population, I think all of us, or most all of us, concluded after culprit shock that it may not be a good idea to do complete revascularization in shock. This is a broader STEMI population with primary angioplasty. It's a staged PCI approach rather than an immediate PCI in the non-culprit vessel. The endpoint is rigorous, cardiovascular death and MI. You know, many of these studies in the past had just used revasc as an endpoint. This is one of those tougher endpoints of cardiovascular death MI. Big study, 3,900 patients. It's open label. Everyone's getting aspirin and ticagrelor. To be revascularized, you have to have a 70% visual stenosis in the non-culprit or a 50% blockage with an FFR less than 0.8. It's interesting to see in this study the introduction of FFR as a qualifying criteria. So it's going to be interesting. It'll be interesting to see if it complements culprit shock or if there's a different answer.
Yeah, I agree with you on the FFR inclusion. I think in light of the FAME series of trials, some other trials, that really understanding whether or not there's functional ischemia is becoming more and more important to the interventional community, and trying to make decisions on the basis of FFR abnormalities is becoming part of standard practice. As you know, in the ischemia trial, we've provided guidance for that group of patients undergoing revascularization that they should be completely revascularized using FFR to guide. And so in this setting of acute myocardial infarction and with ST elevation, I think complete's going to give us some interesting insights. Is, you know, what do you need? Do you need to get completely revascularized, or is dealing with the culprit enough? Certainly, shock, I think, made interventional cardiologists take pause and, as you've said, reflect on how much do you have to do at the acute moment. And the answer is probably just get in there, open up the vessel that's causing the problem, and get out of there.
Yeah, having looked at many, many thousands and thousands of these STEMI films over 30 years as a core lab, I had just seen all these, quote, misadventures when people went around dilating the other vessels, and I was not surprised at all to see the results of culprit shock. I'm skeptical that this will show benefit, but we'll see what it shows.
Last trial. Cabana, NHLBI sponsored trial, along with some industry support, looking at the question of atrial fibrillation ablation versus medical therapy for atrial fibrillation, and looking at clinical outcomes as opposed to some of the smaller trials that have been done in the ablation world, really just looking at persistence of quieting down of the rhythm. Boy, this is an interesting one, given that there are a lot of procedures being done on what I would say, Mike, is a fairly limited evidence base. And what I mean by that is an evidence base that's really looking at clinical outcomes.
Comparing and contrasting the interventional world to the EP world, I like you, I'm somewhat confused as to the evidence base for ablation. It seems limited. This, of course, builds upon the Castle AF trial, where catheter ablation in AF patients with heart failure reduced death and worsening of heart failure. The trial has been criticized, that preceding trial, because it was underpowered, and some of the positive results may not be real, but may be somewhat spurious. This is a bigger trial. This is 2,200 patients, not with heart failure, but with documented AF, who will either receive left atrial ablation or state-of-the-art rate or rhythm control. It's open label, and follow-up is for 5 years, which is a good period. The endpoint's going to be total death, disabling stroke, bleeding, or cardiac arrest. They'll also look at cost and quality of life. So I think it's good. I think it's good to see this widely used procedure, as you said, Bob, held up and tested rigorously.
I noticed you paused and said that it was open label. I think that in light of the Orbita trial, a lot of us are asking the question. One of the things I learned from Orbita is that, number one, you can do these sham control procedures in a group of patients who are undergoing a contemporary cardiovascular procedure. And should that be the standard? Cabana was certainly started many years ago, but if you were to do it today, would you think, well, maybe we ought to do a sham procedure?
I certainly would. Having lived through the VEGF days, where finally doing sham procedures, living through the days of transmyocardial revascularization, drilling holes in the
right, with the lasers.
With the lasers. Both of those were positive in, quote, randomized trials, but were negative when you really did a sham control.
And you did a trial that was big enough to get the clinical outcomes.
Yeah. So I think if this trial was designed today in 2018, I think you'd see a lot of people push for a sham control. I certainly would. I know I might be in the minority there. But I really think we've got to do more sham-controlled trials with these devices.
Yeah, renal denervation is another example where we're really pretty impressed with this procedure. And then when we do the sham control trial, there's no effect of the therapy so compared to the control. So pretty humbling, and I think a good example of being potentially utilizing more sham controls in these procedures. Well, Mike, as always, in 2017, we had a great time looking back. Now in 2018, we had a good time thinking about some of the trials that have come out looking forward. I remain impressed that cardiologists really do demand evidence to change practice, and it remains inspiring that there are so many trials being done by people around the globe to try to answer these questions.
I agree. It's going to be an interesting year ahead.
My guest today has been Mike Gibson, professor of medicine at Harvard Medical School, interventional cardiologist at the Beth Israel Deaconess, and the CEO of the BAME Clinical Research Institute. Mike, thanks for joining us here on Medscape Cardiology.
Thanks, Bob, for having me again.